Hello and welcome to the Healthcare Today podcast. Our guest today is Dr. Katie Barber, Clinical Lead of Community Gynecology, Oxfordshire, and a registered British Menopause Society menopause specialist. For millions of women, the journey from perimenopause to menopause is marked with confusion, frustration, and a disheartening lack of support. This is not a simple failure of individual doctors, but a systemic flaw, which has created a profound knowledge and access gap. Today, we're talking about how women's health hubs offer a fix for the system, and we'll explore the practical steps every woman can take to receive the care she deserves. Where do you see the most critical gaps in understanding menopause? Is it among GPs, women themselves, or within the wider medical community about the long-term health implications?
I think it's all of the above. We have seen a real change in menopause awareness, which is fantastic. Women feeling empowered to go and approach their healthcare professional for support and advice, social media coming alive with clinicians and non-clinicians sharing their own menopause journey and also the importance of identifying menopause. But we've still got more to do. So there's a huge overlap with other medical conditions. And I think lots of other specialties, particularly hospital specialists, don't always recognise how non-specific symptoms can be considered menopause and also the impact of psychological issues as menopause symptoms. So I think it's not that we've got there. We still have so much more to do. But I think the other thing that really I feel we need to think about, particularly for healthcare professionals, is perimenopause. Most patients, if they present to their GP and say, oh, hello, my period stopped 2 years ago and I've got hot flushes, most healthcare professionals will recognise that as menopause. But it's those more subtle symptoms like fatigue, joint pain, insomnia, skin, hair, nail changes, and mood changes, particularly in perimenopause in women who are still having cycles that often don't get recognised, or a barrage of blood tests are undertaken which are normal and we're left with, is this a psychiatric issue? Is this mental health? And I think particularly for some healthcare professionals, they don't feel confident to think about perimenopause and trial hormone therapy where it's appropriate. But also perhaps patients are not aware that all those multiple symptoms could be presenting as a hormonal deficiency. And so you've got both sides not really knowing what's going on, neither wanting to pursue the hormonal route. And sometimes just trying a hormonal route, if it's appropriate, can be really advantageous in terms of resolving those symptoms.
New research from UCL argues that black women in the UK are entering menopause severely underinformed, undersupported, and often dismissed by healthcare professionals. The study found that 88% of black women received no menopause education at school, while 58% felt completely uninformed by the age of 40. Why is this?
Well, there's lots of reasons. And the Swan study showed that women who are of Afro-Caribbean origin have an early onset of menopause. So in sort of around 49.6 years, the average age in the UK is 51. They often have quite prevalent vasomotor symptoms, so hot flushes, night sweats, and also sleep disturbance. Those women also often have a higher hysterectomy rate. There's an increased prevalence of fibroids, 80% of black women having fibroids by the age of 50. So there's a group of women who often present with menstrual disturbance and symptoms that are more pronounced starting earlier. So I think there's an element of healthcare confusion. What is going on here? Is this menopause because it's happening at an earlier age? I think we've still got an inherent healthcare racial bias for these women and also lack of really specific research for certain ethnic populations and cultures. But we also have some cultural impact from views that normalise the perimenopause and menopause transition, and perhaps it not being discussed in communities as effectively as it is perhaps in the white population. And the social networks are really important to think about here, where a lot of women will get advice from elders or family. And if that's not being communicated or those individuals are not able to access culturally appropriate or language appropriate resources, it really impacts their ability to be engaged and get the support they need. So I think we need more cultural specific education and training, resources, think about peer support programs, identifying areas where we could really go into those communities and do a lot more work.
What are the core components of a successful woman's health hub to deliver genuine joined-up care?
Well, I'm going to admit here I'm slightly biased because I lead a women's health hub in Oxfordshire, which, as the lead of the service, I think my service is doing a pretty good job. But actually, this sort of echoes the real ethos of what an effective women's health hub can deliver. So we're talking about a single route of access. Is it easy? Can women access it? And basically my hub processes every single non-cancer referral for patients registered in Oxford. So the GPs don't have to think about where they're sending that patient. They all come through a central portal, which it makes it a lot easier, first of all. So single route, really easy to access, direct from primary care. But it's also equality of access. There's no postcode lottery within that area. It should be that all patients can access those specialist services equally, but also make it manageable for patients. So I live in South Oxfordshire. It's a 40-minute drive if I'm lucky to my main secondary care hospital. The parking is dire and I get hit with the congestion charge if I go a wrong way. So for a lot of patients, it's making those services accessible in local areas. So what can we do about bringing those services out into the community? We also need all the functionality to enable specialist secondary care referral. The IT should be all joined up. Sometimes that can be particularly challenging. But we also need to make sure at the key cornerstone of this is qualified clinicians. Now, that doesn't have to be consultant gynecologists. My hub has GP specialists, but we've got to make sure the skill set of those clinicians is appropriate for the clinical presentations coming through. We've also got to have a really robust admin support, not just to support the clinicians in terms of processing patients, but also being accessible for patients. You've also got to have really good awareness and knowledge of what services are available locally. Where are they? How do I access them? When do I need to access them? And why would I access them? We triage all referrals really promptly. So the other element of a really effective women's health hub is identifying cases that need more urgent input. So are these suspected cancer cases? And that's something we have picked up in Oxfordshire. We've had routine referrals come through where we've escalated them to a cancer pathway, and sadly the patients had malignancy. So it's about all those processes. The other thing that I feel is really key here is not separating primary and secondary care. If you can have some link with the secondary care team with that oversight, and we have a consultant multidisciplinary team meeting every week, you've got that specialist input so that if you have slightly nuanced cases or ones that are slightly more complex, you don't have a delay in processing those patients. They're not waiting 9 months for a consultant outpatient appointment. They've got that input in primary care and we can arrange the appropriate investigation. So it's not just one thing. I mean, if I could write it on paper, I'd be here for weeks, but it's lots of those different aspects joined together.
As part of the 10-year health plan and its scheme to launch a fully digital hospital model, the NHS Online as they're calling it, by 2027, the government has selected menopause and menstrual problems among 9 common conditions on which to concentrate. Do you feel that having clinical advice from home via the NHS app is the right tactic?
I think there's positives and negatives in this. I think on paper, it sounds great, doesn't it? Easy access, convenient, sit at your computer and get some response. But my concerns are the lack of specificity and tailored advice for those individuals. What about the qualifications of the clinicians? What about the information that's in that system? Do they understand the awareness of local pathways and how there may be differences if you're a GP up in Sheffield triaging a case online for a patient that lives in Exeter? Do you know what pathways exist down there? How do you arrange appropriate imaging? And the concern I have particularly for women's health is a lot of women's health problems need face-to-face input. Every week I see patients where the diagnosis has been missed. And actually examination is key here. So whilst it may be good as a triage model to assess initially and decide what the next appropriate step is, I think really the Women's Health Hub model offers a way of those patients being managed appropriately, accessing the right support from the right person at the right time in the right place, which may be slightly lacking with the virtual model.
Investment in women's health hubs is threatened by government deprioritisation. From your perspective, what are the arguments stakeholders should use to make the economic and social case for protecting this funding?
So there's huge benefits to locally based women's health hub services in terms of cost effectiveness. We see about £11 billion in the UK lost annually due to women's health issues preventing women from going to work. So we need to keep these women in work, increase employment, reduce sick leave, and also retain skilled workers who are often in midlife at the pinnacle of their careers often, where they're supporting their younger colleagues and developing them as much as their own careers. So we've got a really key aim here to reduce absenteeism. So we know that women's health hubs deliver faster evaluation, investigation, and treatment. They reduce the duration of illnesses because you're treating these problems more promptly, getting women access to the right help, arranging appropriate investigations, but also making sure that you refer those onto secondary care who really need gynecology input. So you're reducing those simple things that can be managed by GP specialists in the community. For example, if we take menopause in community gynecology in Oxfordshire, around 60% of our patients were going through to secondary care in 2021 for a specialist menopause consultation. And when we incorporated menopause into our model, we now refer just over 10%. So we have some that we still refer who are super complex or women with early menopause, but actually that's a huge reduction in secondary care specialist input. And our waiting times have reduced. So whereas women would wait 9 months, 12 months before for a specialist menopause consultation, we're seeing them within 4 to 6 weeks. So if you get treatment in early and you can manage those symptoms, the insomnia, the joint pains, the vasomotor symptoms, you keep women at work. And actually quite a lot of simple things in primary care we can do that gynecology historically did, like urogynecology, fitting ring pessaries, long-acting reversible contraceptives for menstrual problems as part of menopause, vulval issues. So we deliver increased efficiency at a lower cost, making savings, reducing admissions, and managing those patients that we can appropriately, but also identifying patients who are more complex. So there's huge economic impacts in terms of investing in these services locally at an early point.
Now, if women's health hubs are rolled back or fail to be sustained beyond what you've just kind of outlined, what are the implications for the future of menopause care specifically in the UK, especially ahead of the government's renewal of the Women's Health Strategy for England?
Essentially, this is going to impact more on primary care, and we've seen huge demands on primary care at the moment, with most GPs now going to a exclusive triage model. So we've already got increased demand. We're going to see higher demand for GP appointments for unresolved problems. We're going to see more secondary care referrals. We're going to see more A&E attendances because patients are going to get frustrated that they're not getting answers to their problems. And really, that is a concern in terms of the increasing waiting lists and elective waits for surgery when you're just bombarding a system that's already at breaking point. So the other thing that we need to think about is in terms of looking at the underserved communities, targeting access, thinking about culturally appropriate care. We might see increase in prescribing because patients are not getting the solution, long-term condition burden. So identifying those things, for example, menopause has key impacts on cardiovascular risk and bone density. And if we don't pick those women up early, we're going to see higher risk of fracture, heart disease, and that can be really significant in terms of the long-term cost to ongoing healthcare burden. So I think we've got proven models working across the UK showing reduced referral rates, higher patient satisfaction, time savings. For example, the cost of a primary care consultation is about £37 to £42. Secondary care consultant outpatient appointment, £181. So that's over 4 times the cost of a primary care consultation. So we are making cost savings, reducing repeated attendances, delivering a much more efficient system that achieves wider system goals, and embedding a high-value model into the core neighbourhood health services that we're all trying to achieve.
With menopause care very much on the cultural agenda, what is the most important lever for change right now? Is it political will, medical education reform, public demand? Is it all of the above?
All of the above. I think my statement would be, let's make menopause care a routine part of primary care delivery. So that needs medical education with competent clinicians. We need local champions, particularly for ethnic minority populations, support with education. Do we embed this in locality commission services? Clear pathways where we can escalate. We need to measure all the outcomes as well. I think a lot of the time in the NHS, we don't measure clear outcomes and data. And yes, we need continued awareness, but we need to change the system in order to meet the unmet demand. And we're at a point where we've got phenomenal clinical momentum. We've got social media publicity. We've got real advocates out there in women's health desperately trying to pursue this. And we know that solutions exist and we've got visible demand. So we've got clear opportunity here to make the most of these hubs and let them deliver.
Crystal ball time. What's one thing you wish that every GP in the country knew about perimenopause that they currently aren't being taught?
Gosh, one thing is really hard.
It could be more than one thing.
I think my statement was just think about menopause. In anyone over 40 that's polysymptomatic, even in women who are menstruating, think about perimenopause. As I said, you've got that early recognition in women who've stopped their periods and have got typical vasomotor symptoms, flushes and sweats. But those polysymptomatic women who are having issues in terms of maintaining work life, personal life, social life, think about menopause and don't be scared of the hormonal benefits that HRT delivers outside of symptom control.
If you could design the perfect scalable model for menopause care in the UK, one that doesn't necessarily rely on the postcode lottery, what would its key pillars be?
So I think the key thing here is you need a consistent, scalable, efficient and equitable model. We need universal primary care-led access. So every surgery is doing the basics and then referring in. It should be at a level of standardization so that the service is providing a minimum standard across the United Kingdom, but with flexibility depending on nuanced local populations and service availability. You need clear pathways and guidance. And my wish list, a universal HRT formulary for the UK, so that we don't have this postcode lottery of different populations being able to access different treatments based on a formulary. You need incentives. Embed this within GP contracts and local schemes, and then you get the really good data collection as well in terms of how these services are working. Tiered expertise, so starting with primary care, GP pharmacists, specialist nurses, then GP specialists like myself, and then either secondary or tertiary care gynecology. We can embed advice and guidance, virtual consultations, group consultation models, and they can be then population specific in those areas. Integrate the whole person. So menopause isn't just about hot flushes and sweats and what's going on at midlife. It has sequelae for cardiovascular health, brain health, bone health. And actually, if we intervene early, we have huge benefits for the population going forward. But also make sure that we're investing in training and competency. There's a huge enthusiasm in the primary care world for specialist knowledge, whether it's gynecology, dermatology, ENT. It improves work-life balance for those clinicians that they have a specialist interest that they're extremely passionate about and can actually deliver and utilise. So utilise that experience, embed that learning in primary care for everybody. And then the most important one, I think, probably I'm saying last, let's empower patients. Let's give them tools, like those digital tools, to access information and know what pathways exist, but also give them really high-quality patient information and resources so that there aren't these mixed messages about menopause that cause confusion and fear. There's still that mindset of concern about breast cancer risk with hormone therapy, and that dates back 26 years ago. But that affects both patients and clinicians' views about the role of hormone therapy in menopause. And I think while we are slowly undoing those myths, still more work to be done. So, sorry, it's a bit of a long-winded response, but that would be my ideal model to scale up, which essentially most of those things we're doing here in Oxfordshire. So we're very fortunate to have that model working well.
Dr. Katie Barber, thank you very much for your time.
Pleasure. Thank you for having me.